So we're done with plasma. Let's talk about detoxification. So detoxification. Remember, cirrhosis means destruction of liver, so no detoxification. What does the liver detoxify? Let's name some of them. Drugs. Let's name some drug. Okay, no big deal because nobody ever takes it every day. We're talking about something that the body uses it or produces it constantly. Estrogen. So liver detoxifies what? Estrogen. Detoxifies ammonia. Very good. These two are the most important one. Now, as a result, if liver is supposed to detoxify estrogen, that means you can no longer remove estrogen. So what happens? There you go. Accumulation of estrogen, too much estrogen in men, it will cause problems. So in men it will cause gynecomastia. Female like breast in men. And in female, what would it cause? Excellent. Yes. Amenorrhea, abnormal cycle. Abnormal menstrual cycle or no menstrual cycle at all. Huh? Yeah. Okay, so amenorrhea is the most important one, but you can think of all of them. Now, if liver is supposed to clear urea, how does liver clear urea out of the body? It removes ammonia, converts it to urea. Excellent. So now in this case, ammonia will accumulate. Too much ammonia leads to what? Yeah, CNS defects, right? So CNS, mental status changes. Mental status change. Let's just write that term. Mental status changes, which means confusion, headache, blurry vision. When's your exam? Monday? Okay, if you give me a term for blurry vision, medical term, I give you 5%. Okay, that's one choice. As many as you can get it, so I will not tell you what's right and wrong. So yes, sclerectoris. Anybody else? Huh? I have to hear you. Diplopia, that's another one. Both of you said it, that's okay. Third one said it, I'm generous. Fourth one said it. Anything else? Auction. Cycloplagia. Yeah, remember when I talk about cholinergic agonist antagonist? I mentioned it. If you're paying attention, obviously. Cycloplagia. Yeah. Okay.
So we got 5.
Nope. -5. The whole class could not come up with it. So. Yeah. Okay, so confusion, headache, blurry vision, lethargy, irritation, and essentially coma. Ammonia can completely, cause seizures. Seizures, okay. So that's detoxification of the liver. Of course, that means you have to be careful now in cirrhotic patients to make sure you not take certain medication. If you do, take decreased dosage or too much dosage. Okay, so depending, those medications, so there are two groups of medication. Some medication that are inactivated, detoxified by cytochrome P450 system, those medication should be taken in small concentration because they become toxic now. You cannot clear it, you cannot metabolize it, right? Those medication that's supposed to induce cytochrome P450, you can take them. Those medication that's supposed to inhibit cytochrome P450, oh my god, their toxicity will even more increase. So you have to be careful. And we'll learn those medications. Just know that medication that are cleared by the liver, you have to be cautious when you use them in cirrhotic patient. You have to be aware of their dosage, because the dosage that was normal in a normal person is now toxic in this cirrhotic patient. Does it make sense? Because cirrhotic patient cannot tolerate that same dose. They have less cytochrome P450 system. So they cannot metabolize it, clear it, neutralize it, detoxify it. Anything else? What was the other function of liver?
Is it lipid soluble usually?
Huh?
Is it lipid soluble for medication?
Yeah, that's for absorption. Solubility is for absorption, not detoxification. Yeah. Anything else? There you go. Bile synthesis, we talked about it. That's, again, what? Bilirubin. So now, one thing is bile acid. Liver is supposed to make what? Bile acid and salts. In cirrhosis, you have less of this. So that means fatty food intolerance. Or steatorrhea. Steatorrhea is, yeah, we discussed it before in detail. There you go. Diarrhea, fatty diarrhea. So that can lead to malabsorption, right? Oh, okay.
Wait, it is because of malabsorption.
Yeah.
Yeah.
So decreased bile acid will lead to malabsorption and steatorrhea. Anything else? Yeah.
How does increased estrogen cause amenorrhea? That will be backwards. Irregular cycle.
How does increased estrogen cause amenorrhea? See, menstrual cycle depends on the normal balance between estrogen and progesterone. If the balance is distorted, you will have amenorrhea or any form of menstrual defect.
Have progesterone breakdown. Okay.
Yeah. So if there's irregular menses, no menses, too much menses, it means either too much estrogen, too little estrogen, too much progesterone, too little progesterone, or a combination of the two. Yeah?
Is that because the estrogen maintains the, crown is called the layer that's in the ovary?
Decidual layer.
Does it keep that layer within the...
No, not only because of that. See, when you have too much estrogen, you need for ovulation and for menses progesterone as well. When you have too much estrogen, a lot of estrogen will cause negative feedback on what? Pituitary and hypothalamus. So your own production will decrease even further. Okay? So at the end, there's imbalance between progesterone and estrogen. Balance is must. Okay? Yeah. And this estrogen is not coming in cirrhosis patient. The estrogen is not necessarily coming from the ovary. Even it comes from other cells, non-ovarian cells, not gonadal cells. You just cannot metabolize it, right? All right. What else? There you go. Let's go there. Excellent. The last thing is portal hypertension. Portal hypertension. So now, there are 3 areas. I told you to memorize it or give you homework or no?
Yeah.
Okay. There are 3 areas you're supposed to be responsible for where portal system and caval system anastomose or mix together or join together or fuse. Okay, anastomose means blood vessel coming together. Caval means vena cava. So it's vena cava system and portal system. They will join together in 3 areas. One is in the, give me those 3 areas. Okay, Hani knows.
No, he doesn't.
No, he does. He does.
You sure?
Tell me one.
Hepatic.
That's true. No, there's one where GERD occurs. What's that location? Gastroesophageal junction.
Yes, yeah.
Gastroesophageal junction.
And anal.
Good. Now we're talking. See, this leads to what? Varices, right? So lower esophagus. The other one is?
Anal junction.
Anal canal. So very good.
Anorectal.
Okay. External and internal anal junction. What is that line between the external and internal anal canal? Pectinate line or dentate line? Okay. Okay. Anal canal. So anal canal. which is the junction between squamous and columnar epithelium. Good. One more.
Around the umbilicus.
Excellent. Excellent. Actually, it's a bonus. Umbilical region. Good. So 3 areas. Now, this is your job. I want you to memorize for Wednesday the name of veins that form these anastomoses or plexus. You got to memorize the name of veins. I already give you homework for venous and arterial supply of rectum. So it should be not, that should be just a review for you. But gastroesophageal junction and umbilical region, you have to know the name of veins. One vein is from systemic, one is from portal vein. A branch of those. They come together, so you got to know those. Now, as a result, portal hypertension can lead to, what are the complications of portal hypertension?
Varices.
So varices, very good. And how about an inner canal? How about an umbilical area? Rash, but there's a name for it. Caput? Medusae. There you go. Or, what did you say, Isna? Ascites, sure, it's a complication of this, yeah. No, but the engorgement of these veins, skin veins on your umbilical area, they will engorge. You will see them as if there's a spider. Yeah.
Spider navia.
You can use that too. Or angioedema. You can use angioedema, spider navy, and you can also use caput medusae. Yeah. Okay, there you go. Who's Medusae? Or Medusa?
She had like snake hair.
Yeah, she
and
The one you look at, she becomes rock.
no, you turned to stone.
You turn to stone.
So if I look at her, she becomes stone.
No,
You
she
look
looks
at her
like you.
eyes. You turn to
You
stone.
look.
Where is she?
She's myth. It's not real.
Oh, so she's stone. Okay.
Yeah, in the story of Hercules, he made her look at herself in the mirror.
Yeah,
And she turned
and she
herself
turned
to
to
stone.
stone. Yeah.
Oh, I should be friends with Hercules. All right. Or octopus. You can call him an octopus rash. Spider rash. All right, good. So know those. Now, of course, this leads to rash, umbilical rash, hemorrhoid, and varices. We've discussed varices before, hemorrhoid before. Now you will have umbilical rash. The rash should be dark bluish, and you can feel it. It's subcutaneous veins, right? It's not deeper veins, because otherwise you will not see it. Okay, sometimes this can be confused with Cushing's disease, and they can be confused with stretch marks. Sometimes it can be confused. Okay, but it's clear cut. You cannot you can differentiate them. Good. Cushing's produce similar rash. Yeah, very similar. Okay, there you go. So that's cirrhosis. At the end of the day, you should have no problem with cirrhosis. All of these are possible in cirrhosis. But of course, the first sign is what? Jaundice. Jaundice. And the most important complication is portal hypertension. The rest you can figure out. Okay. Now, in terms of test, how would you diagnose cirrhosis?
ALT, AST.
So let's say blood test. Very good. Blood test. What are the markers for cirrhosis then? ALT,
Aspartate transferase, alanine transferase.
AST. What happens to them? They should be increased?
Yeah, they're increased in blood.
Are you sure?
No decrease,
Why decrease?
because it's gonna decrease the urea. Because
If we have them,
hold on.
Huh?
Because your proteins are not synthesized.
Oh, because this is cirrhosis. So there's not
Where do you find these enzymes?
It's on hepatocytes.
They're,
hepatocyte. Inside the hepatocyte.
I like the enthusiasm. That's how you should be. You see, when you learn something, you want to share it, right? Every day should be like that. Every day. Good. I'm happy. Now, where do you find ALT and AST?
In hepatocytes.
Within hepatocytes. So the only time you should find them when the hepatocytes rupture and they release into blood. In cirrhosis, what happens to hepatocytes?
There aren't any.
They're destroyed over a long period of time, so there's not enough. So they should be decreased or normal. Okay, they shouldn't be. They're not indication of cirrhosis. AST and ALT are structural markers, not functional. So let's talk about liver test, okay? So blood test in liver, there are two types of blood tests for liver. Liver functional test, that's one. Liver functional test and liver structural test. Is that good? I like the long, oh.
It is. It's good.
Liver's functional test is, what can't liver make? What does liver make? Bilirubin conjugation. That's one. Anything else?
Albumin.
So it's a conjugated bilirubin. And
Albumin.
albumin. Anything else?
Complement.
Urea. Anything else?
Clotting factors.
Clotting factors. Excellent, excellent. Especially, let's say, clotting factor 7. Clotting. Huh? This is a huge marker. What is structural test? Yeah, AST, ALT. Okay. Now, one more. So, we're not going to use albumin. Usually, it's not. I mean, you can use it. I'll just keep it. And let's include one more thing, cholesterol. Okay. Now, in this case, what should happen to conjugated bilirubin in cirrhosis?
Increases.
No, it decreases.
Decrease. And what should be increased?
Unconjugated.
Unconjugated bilirubin. Unconjugated bilirubin. Okay, so bilirubin will be increased. Total should be increased. Unconjugated should be increased. Conjugated, maybe normal or decreased. Okay. All right. How about albumin?
Decreases.
Decrease. How about urea?
Decrease.
Decreased. How about ammonia then? Excellent. How about clotting factors?
Decrease.
Decreased. Especially factor 7 is easy to measure, okay? How about cholesterol? Increase. Good. All right. Anything else? No? Okay. So look for those things. That should tell you. What else would you do?
CT.
Okay. CT. And what else?
MRI.
MRI?
Biopsy.
Okay, I'll keep it.
How about biopsy?
Biopsy.
Ultrasound.
Abdominal ultrasound. MRI, CT scan. Okay, so I'll just put abdominal ultrasound. Anything else? Okay, what would you say on CT scan?
It's not the shape.
Okay, so liver is slightly smaller compared to before. Yeah, you might not be able to see that. You have to be highly trained.
Would you have cysts on it?
No. No. On CT scan, you might see splenic enlargement. Splenic enlargement or edema or congestion.
Can we do a diagnostic laparoscopy?
You can, but it's not needed. Let me tell you a little bit more, okay? MRI and ultrasound, what would you see? Nothing. It doesn't tell you much. CT scan, MRI, ultrasound. Again, if you will look for liver edema, splenic edema and congestion and engorgement of the splenic artery, sure. You were asked questions on that in the anatomy, remember? Biopsy is the next test. This is the ultimate test. First test is blood test. Second test is what? The gold standard is what? Biopsy. What would you find on biopsy?
Lots of collagen deposit.
Yeah, so cirrhosis. Cirrhosis, the term cirrhosis you'll find on biopsy. Plus also portal triad destruction. Okay? And then of course fibrosis, calcification and blah 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 blah.
So we do blood tests and then we do biopsy right afterwards?
Yeah, you don't need to do CT scan MRI. They won't help you. They won't help you. Now biopsy, what would you do? Fine needle aspiration. You don't have to do laparoscopic. Just insert a small needle between the ribs, right? Which ribs? Between 8 and 9? Okay, that's good. Which one?
Right.
Thank you. So say that. Right, 8 and 9. Okay, where exactly? From the front, from the back, from the side? Okay. So you can do it
Anterior axillary.
from anterior is better. Okay. Yeah. So because on the flanks you can actually damage the diaphragm. Diaphragm is dome shaped backward. Okay. Or sometimes kidneys. So anterior is much better. So if you go anteriorly, now what else would you do? You know when you have ribs, let's say this is rib 7 and this is rib 8. What's the space between them called? Intercostal space. So where are you going to insert the needle?
Down.
On the superior border or on the inferior border?
Inferior border of 7.
Okay. Why is that?
Those nerves and
Superior
arteries.
border of 8.
Yeah. So be careful that just go exactly in the center. Okay. Yeah. All right. Remember that when we talk about, you remember when whenever I draw lungs or the spaces, pleural spaces, I go like this. That means there's that space where is the pleural space. So if you insert the needle here, although you have a liver here, you go here, you might puncture the lungs or the space. Okay, so you might introduce unnecessary, or you will get fluid from here.
To expire.
Yeah, it's not necessary. So go from the front. All right. What is the treatment?
Lifestyle modification.
Liver transplant.
Yeah, the cure is liver transplant, but you might have to make sure they stop drinking. You do symptomatic treatment, give them clotting factors, fresh frozen plasma, blah blah. All those things we'll learn. So it depends what it is. Depends what they're mostly complaining of. Okay.
How chronic it is.
Yeah.
So
The cure is only liver transplant.
Good question.
Yeah.
So how come we can't resect the liver and let it grow back?
It's difficult. You know, when it comes to cirrhosis does not mean that, you know, you have one lobe. If it's lobar cirrhosis, you can do it because it's diffuse. You know, you cannot pinpoint like, oh, this area is cirrhotic and this is normal. It's difficult. It's too much. Okay, so if it's lobar cirrhosis, yeah, you can do something about it. If it's non-lobar,